Hello, my name is Marc Maegele, and I'm a trauma surgeon with the Department of Trauma and Orthopedic Surgery at the Cologne-Meher Medical Center in Germany. I'm also head of the Department for Research and Operative Medicine, which is affiliated with the University of Witten-Herdecke. The title of my talk today is The Role of Coagulopathy in TBI. And as we all know, TBI and coagulopathy remain the major killers in trauma. And this has nicely been shown by huge retrospective data analysis using different databases in the US, but also in the UK. And as you can see, the last one was published back in 2017 by Oeni and Injury, showing that TBI and exsanguination still account for more than 50% of all death within the first 48 hours after trauma. And when these two entities coincidence each other, the prevalence of coagulopathy in TBI patients is quite high and has been calculated at approximately between 32 and 35%. This obviously translates also into outcome. So when both entities coincidence, the mortality of patients is quite increased and ranges between 50 and even 90% at maximum. This has also been quite nicely shown by our last study we conducted in the context of our huge pan-European center TBI study involving almost 600 patients. All these patients, or the majority of these patients, had sustained a severe traumatic brain injury as reflected by the IS-4 brain equal or above 3 in over 80% of all patients within this cohort. And the frequency of coagulopathy in this cohort was about 20%. And most interestingly, around the same number or the same percentage of patients also were on pre-injury antiplatelet or anticoagulant medication. And the overall death rate in this cohort was 16%. We also looked within this cohort for independent risk factors associated with coagulopathy, acute coagulopathy in isolated TBI, and found the following three injury characteristics as being independently associated with the occurrence of coagulopathy in isolated TBI, and these were the presence of a Glasgow Covert scale equal or less than 8, hypertension, and base access upon arrival of the patient in the emergency department of less than or equal -6. So basically, shock patients had a very high risk of being or developing an acute coagulopathy after their traumatic brain injury. And the mechanisms behind this coagulopathy of TBI are quite complex, as outlined here on this slide, which has been published in the Lancet, but also in the Seminars of Thrombosis and Hemostasis 2020. And the key drivers that basically trigger hemostatic failure or hemostatic disorders associated with TBI are tissue vessel injury with subsequent blood-brain barrier disruption and hyperperfusion and shock, as outlined also in our recent center TBI analysis. And these two major events obviously trigger further downstream cascades that obviously lead to progressive or new hemorrhagic contusions within the brain in these affected patients. And obviously, there are also quite a number of pathways involved that, especially in the context of hyperperfusion and shock, trigger the protein C pathway with activation and inactivation of factors 5 and 8, but obviously trigger fibrinolysis through the activation of tissue plasminogen activator and downregulation of PI1. And obviously, when you load the patient with fluids, there is the involvement of the lethal triad of death, which constitutes of already existing coagulopathy together with acidosis and hypothermia. And there's also, at least in some patients, DIC involved that's obviously triggered by local release of tissue factor. What has also been nicely shown over the last years that even when the patients do not present hemocoagulative with hemocoagulative insufficiency upon emergency room arrival, these patients can develop significant coagulopathy over time. And this has nicely been shown by this nice work by Gruyters from the Netherlands, published in Critical Care already about a decade ago, that the number or the percentage of patients that actually that do develop a coagulopathy after TBI may double within the first 24 hours after impact. And this shows you the evolvement of hemostatic failure in a severely TBI patient that was treated in our trauma center around half a year ago. As you can see here on the initial CT scan, there was only little bleeding on the right temporal in the right temporal hemisphere, and the coagulation profile upon emergency room arrival was quite within the reference ranges, and this was true for point of care viscoelastic testing and also for the conventional coagulation assays. But then the patient during his later course deteriorated and was put again into the CT scanner 3 hours after admission because the clinical course significantly got worse, and the CT scan 3 hours after admission then showed a severe increase in intracranial hemorrhage, substantial enlargement, along with substantial coagulopathy, as reflected and outlined here by the viscoelastic assay and viscoelastic trace, and also when we look at the results from the conventional coagulation assays. Courland already back in 2012 stated and observed that approximately 50% of all patients with contusions demonstrate hemorrhagic progression on serial CT scans. And these pathologies may involve not only the expansion of already existing contusion, but also the occurrence of delayed non-contiguous hemorrhagic lesions. And what's also been interesting to observe was that hemorrhagic progression was equally common even in patients that did not undergo a surgical intervention. And obviously, the occurrence of hemorrhagic progression was uniformly associated with dramatically worse outcomes in these patients. And this has also been replicated by quite a number of studies thereafter. And this shows you a CT scan which shows the evolvement of initial hemorrhagic lesions on CT scans captured on hospital arrival and 6 hours later, but also at 3 hours, as you can see here on the right-hand side. There's also appearance of new lesions at remote locations, not initially affected or pathophysiological affected on the first CT slice. And the hypothesis that has been discussed to provide an explanation for the occurrence of new lesions at remote locations within the brain includes that the penumbra and other surrounding regions obviously receive less energy as opposed to the initial contusion site. At those locations, this energy is obviously not strong enough to parallel initial events, but on the other hand side, may activate the translocation of mechanosensitive transcription factors that obviously infuse in endothelial cells. And once these channels are inserted into the plasma lamellal membranes of endothelial cells, once activated, these endothelial cells undergo cell death and capillary fragmentation. And obviously, this leads to hemorrhagic progression of initial contusions. What's also been quite frequently observed over the past and what's also our impression from daily clinical care in emergency departments, that obviously the frequency of TBI with bleeding and coagulopathy is consistently increasing, and this is obviously related to a demographic change. Today, low falls are the most common cause on mechanism of the TBI, and there's also increased use of anticoagulant drugs that obviously make patients prone for contusion and intracranial bleeds, and also hemorrhagic progression. And obviously, we saw, due to demographic change, we saw more and more people with really substantial comorbidities that makes also the patients prone for bad outcomes. And if we look at the use of anticoagulants, there's also this trend that more and more patients with comorbidities, they obviously are being treated with anticoagulant drugs, and mostly the most common change is that we do see less patients on vitamin K antagonists, and we see an increasing number of patients on DOACs such as novel antithrombin inhibitors and factor 10A inhibitors. And we also have looked in the context of our most recent center TBI analysis on a subgroup of patients being treated with those drugs. And those patients on average were older, they had more comorbidities, they were more coagulopathic, and obviously their outcome was substantially worse as opposed to patients that without a pre-injury antiplatelet agents or anticoagulant. And this is an example of a patient we treated that has been delivered or admitted to our emergency department at times where we did not have access to any specific antidote against a novel antithrombin medication. And this patient was on dabigatran. As you can see here, we ran a second follow-up CT scan 2 hours after admission, and you can see a severe increase in intracranial hemorrhage in this patient. And the patient then was taken to the OR for acute neurosurgical intervention. And this obviously was a life-saving procedure for this patients. When it comes to diagnostics and therapies for patients with hemostatic or hemocoagulative failure upon emergency room arrival after TBI, there are several guidelines out there. I want just briefly allude to you to the European trauma guideline that also has a section on patients with TBI. And this trauma guideline was updated for the fourth time back in 2019. And one of the key messages that was forwarded by this European trauma guideline was that the request that measures to monitor and support coagulation should be initiated as early as possible and used to guide goal-directed treatment strategy. And there is still debate which tests would be most suitable to detect early coagulopathies in patients with TBI. And there is always this debate between the use of conventional coagulation assays versus viscoelastic testing-based assays. And it has to be stated that standard tests obviously have longer turnaround times, and they provide only limited information on the quality and the dynamics of clot formation and clotting. And for viscoelastic testing assays, obviously, they provide more rapid results that can be integrated into clinical decision-making, as they can be used as point-of-care tests, and therefore provide reliable information on clotting initiation as reflected by the clotting time, dynamics of clotting, and the quality of clotting in terms of stability of the clot that's being built up or sustainability of the clot. And this very briefly outlines you the test principle, where basically there is an ex vivo initiation of the clotting process within the cup of a blood sample of the patient by adding a coagulation activator. This clot formation increases the resistance against the rotating cup or the rotating pin, and this resistance is then translated into a characteristic Rotem curve. And this is a characteristic Rotem curve that occurs then on the screen with the characteristic functional parameters. And you can easily distinguish just by looking at the curve a normal clotting process, a delayed clotting, hyperfibrinolysis, or reduced clot strength. And there's been much debate over the past in how to implement this technology into clinical decision making. This is just an example of an algorithm that has been issued based on common consensus, based on Rotem and tag trace, which is then translated into recommendations for specific hemostatic therapies. And this is just a brief outline where one of these algorithms has been implemented in the centers formerly naive to thromboelastometry. This again is a study that has been conducted in context of our Pan-European Center TBI project, and the outcome was adherence to the algorithm and timing of availability of test results against conventional coagulation assays. This algorithm was implemented in 4 European trauma centers. 32 patients were involved, and complete adherence to the algorithm was achieved in 20 out of the 32 cases. And what we also observed, again, that the time of availability of meaningful test results that could be implemented into clinical decision was much faster when viscoelastic testing assays were used. By using this algorithm, there was a substantial increase in clot stability could be achieved as well. One word about fibrinogen. Fibrinogen is coagulation factor, also considered coagulation factor 1. It's the first coagulation factor that reaches critical levels in trauma, is a substrate for clotting, and it decreases as a function of injury severity, also in TBI patients. And this shows you a nice example of the effect of fibrinogen supplementation to a dilated clot. And you can see here the rarefication of the fibrinogen could be reversed just by the administration of fibrinogen concentrate. One word about tranexamic acid, TransCrash2. There has been a huge debate also to use tranexamic acid in context of TBI. The same protocol was used for TBI patients in the CRED3 trial, and there was only a benefit observed after excluding patients with a low Glasgow Coma scale and bilateral unreactive pupils. And a follow-up study that assessed the effect of out-of-hospital tranexamic acid versus placebo on the 6-month functional outcome. There was no benefit in the TXA group, but there was higher frequency was seen for thromboembolic events. Obviously, there are effective strategies when there is anticoagulant use in the emergency setting. For example, if patients are treating with vitamin K antagonists, obviously vitamin K or 3 or 4 factor PCC are the drugs of choice. There are yet available specific antidotes for factor Xa inhibitors or thrombin inhibitors like adixanet alpha and izatuzumab, and obviously protamine so far is still the drug of choice in cases of heparin intake. Well, one last word about platelets and the reversal of platelet inhibitors. The European Trauma Guideline obviously suggests the maintenance of a platelet count above 100 in patients with ongoing bleeding and TBI as a week 2C recommendation. And the Trauma Guideline also suggests the substitution with the platelet concentrates if platelet dysfunction is documented with continued bleeding and in patients who have been treated with antiplatelet agents. In neurosurgical patients or patients with intracranial hemorrhage, the supplementation with platelets is recommended in patients who will undergo surgery. If the patients are not undergoing surgery, this strategy should be avoided. So in conclusion, TBI and coagulopathy remain the major killers in trauma. About every second patient experiences hemorrhagic progression of their initial contusions. Anticoagulants and antiplatelet therapies are additional risk. The early detection, monitoring, and measures to support coagulation are key for improved outcomes. Viscoelastic testing as point-of-care devices provide an option for rapid and individualized therapies, and effective antidotes and reversal strategies are available in the context of anticoagulant or antiplatelet use. And with this, I thank you so much for your attention. Thank you so much for being part of this conference, and I'm happy to take any questions later on. Thank you so much.